All right. So we're going to order from back all the way to the front. Make sure you get your picture taken and your shirt size. Otherwise, you cannot do your ride along time. If you don't do your ride along time, you cannot pass the class. Any questions? All right. That's very authoritative, Dan. All right, let's turn this down. This is a very important chapter. This is a new chapter. It's only been in about a year. It's a very important chapter because if you are not able to operate in a team environment, you will not be able to function as a DMT. It requires multiple agencies at multiple levels for all the gears in the big EMS machine to work. And who suffers if it doesn't work? The patient. All right, life is loaded with good news and bad news. Pretty small print, so I'll read it for you. The bad news is bad things are going to happen to you. People are going to be mean to you. They're going to treat you like dirt. They're going to steal from you. They're going to try to damage you. They're going to say horrible things to you and about you. There's no shortage of these bad people out there. There's no shortage of bad things and bad situations. There are endless things that are going to go wrong and could affect your life and your happiness. And it will happen to everyone at some point in their life. The good news is you control everything that happens to you after something bad happens. You control your attitude, you control your viewpoint, and you control the choices on how any bad thing, bad person, or bad situation affects you. That is entirely up to you. People who live happy lives and do bad things and bad people in the past, they use the horrible things that happen to them to build themselves a better life and not have chronic problems and making the same mistakes again and again and again. You also have people who blame others, objects, situations, what happened to them, what happened around them. They're chronically unhappy and they're never able to move forward because they feel others control them in their choice situations. Until they break that mindset, they will never have a happy and fulfilling life. Truer words have never been said. You have no control over the thoughts, actions, and words of someone else. You have 100% control of how other people's thoughts, actions, and words affect you. Who you are is who you will become. Never be bitter, unhappy, and angry over the actions of somebody else. Those actions are theirs. Learn from your actions and situations around you. Become the best you that you can be. Any questions? You're going to be working in a field that is loaded with negative things and negative things that happen. How you handle that and how you deal with it is what will make or break you. And only you will have to be blamed if you get broken or if you can't make it through it. Any questions? All right. So you're going to learn about continuum of care. You're going to learn about the 5 essential elements of a group. You're going to learn what the difference between a group and a team is, what the advantages of being a team is over being a group. You're going to go over resource management, the benefit of having resource management EMS. You're going to go over the 5 critical elements necessary to effectively transfer patient care from one provider to another. You're also going to explain the stages of effective decision making, describe decision traps that can lead to decision errors, and describe the steps of how you troubleshoot interpersonal conflicts. Again, what you choose to do is what makes or breaks you in an interpersonal conflict. Any questions? All right. You are one part of an integral life-saving team. As an EMT, you're going to be a critical part of that team. That team cannot survive without EMTs. It will not work. Any questions? So the positive and negative culture. Trust, teamwork, communication, sensitivity, and mutual support. Things that will destroy a team and affect the patient: lack of communications, taking shortcuts, not following policy and protocol, punishment, poor teamwork, and people just doing things that they think is best despite what they've been trained and what they're supposed to be doing. Any questions? All right. If you're not able to work in team integration, your patient will suffer. Seamless team is from first responder all the way through the ER staff to surgery. That's called continuity of care. Any questions? Sir. All right. Any question about continuum of care? All right, so different types of teams. You've got regular teams, temporary teams, special teams. Which is not the same teams that are on kickoffs and punts. I know that's what some of you are thinking. Next. All right, regular teams. Regular teams train together. They usually work together the same shifts, even though they're from different agencies. Results in a faster, smoother working team, as everybody is familiar with each other, everybody knows what their roles are, and everybody is able to work seamlessly together. Yes, sir.
You're missing an O.
Where?
Smother team. The last, yeah.
Yeah, that's for when, that's the hit team. Mother.
Yeah.
Thank you.
Without the pillow.
That's the team we showed you, that team on the first.
Oh,
class.
that was the smother
That
team.
was the
Okay.
smother team.
All right.
Put the guy prone on the area.
Smothered to death.
Amazing paramedic and EMT. They were just fantastic. They're wonderful people.
Different disguised as paramedic.
My God. So anyway, example, generally, the teams I work for the week, it's the same shift for the fire departments. When I work for the fire departments, it's usually the same people. Same thing with the ER staff. When I come to the ER staff, I usually am working with the same doctor and the same ER nurses pretty much about 80% of the time. So that same integration goes all the way through. That's the Monday through Friday team here in South County. Now, sometimes I go to North County. I don't work with those people as much. That's not a regular team. Does that make sense?
Mm-hmm.
Still a team, just not a regular team. Next. All right, temporary teams. That would be example when I go into a different area. This is when you work with people you don't normally work with and you don't normally train with. So if you try to compete with each other, it's not going to work. You got to have open communication, be supportive of each other, and make sure everyone's clear on what role they're playing and what they're doing. If you're not working with those people regularly, does that make sense? If at all possible, if you know you're going to have a temporary team, you should get together and do as much joint mutual training as possible. Keeps you on the same page. Any questions? All right. Special teams. Usually come in for the kickoffs and the punts. That's what's good. These are teams that have generally a specialized training that get together in specialty situations. Things like confined space rescue, swift water rescue, urban entrapment, hazmat, tactical weapons teams, special event standbys, things like that. Any questions about special teams? So, next. So a group, what's the difference between a group and a team? Group is people that work independently, even though they're all there together, they don't work cohesively. There are multiple different agencies that are all on scene and they're all working, they're not working cohesively, they're not working together. They have to share the common goal, get the patient to the hospital, but they are a group, they don't work, and they're not an integrated agencies. They share the same values, but they don't work together at all. They have self-assigned roles for the patient. I'll give you the example. Try not to offend anyone. We're going to change the names, protect the innocent. So, 50 years ago, I was on a fire on the Utah-Virginia border. Change the names to protect the innocent and the years. Yes, the Utah-Virginia border. Same fire, person got heat exhaustion. So both states, Utah and Virginia, were on scene. They both called for ambulances, both had incident names, and we're both fighting the fire, same fire, with a different incident name, a different incident commander, and we're ordering resources completely independent of each other. That's a group. That's not a team. Make sense? Then when the firefighter got in the ambulance in Virginia, he was a Utah firefighter, so tied you, pulled him out of the ambulance, put him in the Utah ambulance, which also got. So he wanted to go to Utah, not Virginia. Any questions? True story. No questions. You don't change the protect the incidents. Innocent people will get very upset, disturbed, and then you'll be the bad person. It's how you handle the situation. All right. 5 essential elements of a group. They have a common goal. They know they're a group. They have the same sense of continuity. They understand who the other people are, and they have the same set of values, but they self-assign themselves roles, and there is no commander or no person in charge. They are not working as a mesh of gears. They're working as independent gears. Any questions about the difference between a group and a team? Any questions on what a group is? All right. So different types of groups. You got dependent groups, independent groups, and then interdependent groups. You guys probably didn't see that one coming. All right. Dependent groups, when each individual is told what to do and how often to do it. They have their own leader within their group. Now there may be multiple ones on scene. They have a limited ability to adapt to deliver emergency care in an uncontrolled field environment because they're waiting for direction. They cannot act quickly on how they've been trained to act. They don't act and work cohesively. Any questions on what a dependent group is? Independent groups. Each individual is responsible for their area and their role. And they might get guidance from a leader, but they don't really wait for them to give assignments. Where you run into trouble is nobody's directly in charge or monitoring or watching out for the patient. Everybody's just kind of doing their own thing. So example would be a patient that's brought to the ER with a great perfect splint, but they're dead because nobody monitored the airway. Great example. Any questions? On interdependent groups or independent groups? Interdependent group is next. An interdependent group is a true team setting. That's what a team is. It's a group that works together under a single leader, has shared responsibilities. They all have the same goal and they're all working as an integrated team with the general outcome of the patient. It's not about the group, it's about the patient. An interdependent group is basically. Yes, sir.
So how come if this would pretty much yield the best outcome the majority of the time, why would anyone do anything else?
You're new in emergency services. There is an enormous amount of pride and ego in all emergency services. And every agency considers themselves the best in the elite agency. So Virginia is not going to take the orders from Utah and do things like Arizona, because they are the elite. That's it. That's sad, but true. So yes, teamwork and communications on large scale incidents or even small scale incidents is difficult at best. Any questions? And you will see it the more you work into this field. All right. You mean, why doesn't everybody make it about the patient, about saving lives and property?
Why would we do that?
Who am I to say? Next. Who's next? So how are teams effective? How do they perform effectively? First of all, everybody's got to have a shared goal. Everybody's got to be aware of what the goal is. They got to be committed to it. For example, a pulseless apneic patient, the goal is to give high quality CPR until you get ROSC. Now, who is ROSC? ROSC is return of spontaneous circulation. In other words, getting a pulse back, bringing them back to life. The ultimate Easter Sunday. Any questions? All right. They also have clear roles and responsibilities of everybody within the team. Everyone knows what needs to be done and which role each person is playing. A lot of people refer to as a pit crew. Pit crew can change 4 tires. I'm not a NASCAR fan. How long? No NASCAR fans?
Pretty quick, just like half.
How fast?
It's like a second, second.
Seconds. You know how long it takes me to change 1 tire? About a while, half an hour. Gotta find the jack first, somewhere underneath the spare. Get the donut out, stop, breathe for a little while, let the sweat off my brow. But in the pit crew situation, they get 4 tires changed in seconds. All right. So they got diverse and competent skill sets. In other words, there's different levels of skill within that team. Next. Any questions? Next thing, they have effective collaboration and communications. They are clear with each other when they talk to each other. They identify each other by name, rank, and specific task when they're doing it. For instance, paramedic Chris, in charge of airway. Someday. Someday. You have closed loop communication. They speak back to each other. They repeat it back. It's called reflective listening. Please hand me the 14 gauge needle. Paramedic Witherell getting you the 14 gauge needle. That way, the person that made the command or the request knows that you understood it because you repeated it back to them. Any questions? Also courteous and they're pleasant, and they have constructive intervention. If somebody sees something they don't think is right, they don't say, Jesus, what the hell are you thinking? Bring it up in a constructive manner. Say, confirming you would like me to do this and not this. 6 to 10 eyes is always better than 2 eyes. But another set of eyes is not effective if it's not presented properly. Any questions? So the leader of a true team is responsible for the assignments, the oversights, coordination, centralized decision making, and general support of the team. It can never be about the leader. They have to be able to take criticism, they gotta be able to take constant changes in it, and constantly be able to reassign for the benefit of the patient, not their ego. We need to assist the team in the goal by making sure each team member has the ability to do the job that they have been assigned. They also are in charge of communications dynamics, resource management, and situational awareness, making sure everyone is aware of changes in what is happening. They direct the entire group. Any questions? By the end of the semester, we'll taught you all how to be team leaders. The team will only be as strong as its weakest link. As team members, if you have someone that is a weak link, it is up to you to help them, get them strengthened, and up to task, work with them. Nobody can work alone. None of this, I don't care how good you are. I don't care if other people tell you you're the best there's ever been, and you believe that, you still can't do it. You've got an extra set of hands with you. Have to have a team. There is no lone ranger in EMS. Everyone has to have good communication, be able to accept feedback, have confidence in what they're doing. How do you build confidence? You do it again and again and again until you have done it so many times, you cannot get it wrong. That's why we do what we do here. You also have to have compassion, you have to be mature. And above all, you have to remember, it's not about you, it's about the patient and their family. Good team members treat each other with respect regardless of their rank and seniority and their strengths and weaknesses. Everybody is responsible for the safety of the patient and each other. Any questions? CRM. Sounds like software. Crew resource management. Is when you work together and develop a shared understanding of the situation. That allows multiple groups to work together as teams that have different skill sets to communicate and fulfill their roles and responsibilities. Let me give you an example. You get a car wreck on a freeway with someone trapped. You're gonna have a group of law enforcement there. You're gonna have a group of firefighters there. And you're gonna have a group of EMTs and paramedics. They all have to work together with their specialized skill sets. Make sure that patient's extricated and gets into surgery as quickly as possible. Next. So it can't be done if the police are not making the scene safe, blocking traffic, making sure emergency resource get in and out. Doesn't happen, the fire department doesn't have their tools, they don't know how to operate their tools for extricating the patient, getting them out. Doesn't matter if they don't have the EMTs there and they're not doing the prep work to get the patient packaged, ready for transport, and setting up the advanced life support. Doesn't work if the paramedics not there doing the IVs, doing the advanced airways, doing the cardiac monitors, pushing the drugs for this patient. Does that make sense about integration of special skill sets? Paramedics over there telling the firefighter how to use the jaws. That's not going to work. Any questions? All right. And always speak up. If you see something wrong with the jaws, you might say to the leader, hey, just confirming we want to do it this way and not this way. Because this is what I'm saying. You say it politely and have them repeat it back to you. Might be something you're missing, might be something you notice that they missed. That's how a team works. If someone's getting offended by a question or noticing something, that's not really about the patient, is it? It's about them. They're offended. Next. I think that's you, Max. There you go. Any questions? Any questions about 10 eyes versus 2 eyes? But spiders make great team members, lots of eyes. Just kidding, I hate spiders. Anyway. Transfer care. Single person should be doing the communication for the team. All right, goal when they transfer care from one group or team to another. Uninterrupted care, minimal interference, respected interaction. Make sure the problems and the priorities are listed. Make sure everyone's on the same page. The terms and terminology and medical terminology. We teach you guys start triage at the end, you're gonna go, wow, that seems pretty simple. It's not as simple as it looks, because before start triage, which you're gonna learn the last day of class. Every agency has their own triage system. So when you have 30 agencies on scene of a plane crash or a bus wreck or a train wreck, you have 30 different versions of triage going. That doesn't work. You can't operate as a team. Any questions? All right. You have to remember this. You remember nothing else, remember this. 90 to 99% of all patient care is basic life support done by the EMTs. The advanced life support from the paramedic may come in and start an IV and push a medication. Everything else is the same as an EMT. Next. Any questions? Make sure you know your equipment. If you're an EMT, make sure you know how to set ALS equipment up. That's part of your team, part of your priorities of being part of the team and the job. Any questions? Conflicts. Whenever human beings are involved, there's going to be conflicts. The good news is not everyone's going to hate you. Bad news is not everyone's going to like you. So you have to be able to identify and resolve conflicts quickly, because again, it's not about you, it's about your patient. So, professional team conflicts don't happen. When they do happen, remember, patient comes first. If someone is being inappropriate and unprofessional, do not engage them and make it worse. You stay cool, calm, professional, isolate the issue or that person, choose your battles. Those things are handled after everything's cleaned up and done. Then you identify what the problem was, you form a plan to fix the problem with measurable benchmarks to make sure it gets fixed. Questions? Next. All right. Next slide. Actually, there won't be another slide. Anybody have any questions about team integration? All right. Moving on. Oh, this is a good one. Patient assessment. Kind of an important chapter. So remember the goals of EMS. They'll do a good scene size up, good patient assessment, looking at the positive findings that patient assessment, perform a primary impression, and then choose a treatment protocol based off that primary impression. Treat the patient, give them the definitive care, get ready for the next emergency. Any questions? All right, chapter 11. So, next, team support. This is one of the best team support videos I've ever seen in my life. Here's something I hope will work.
What happens when the prostate enlarges and the urine channel gets tight? If you
Has nothing to do with your prostate.
have an enlarged prostate, do this for
Bring down fast. Run fast. Let's go, boy. Well, Paul, you gotta take your feet. Come on. Make it fight, sister, go. Now hit hard. Yes, you can do it. Come on. Yes, you can do it. You gotta do it. You have to hit it hard, though. You cannot hit it light. You have to hit it hard. Go. That's not hard. It's touch it.
That team is going to go far. All right, there's your algorithm. You guys know this. We've been working on it since the first night. Question? Or you just
No,
stretching?
I'm just stretching.
Stressing or stretching?
Stretching.
A little bit of both.
So, team size up. You guys have that memorized, right?
Yes.
Yeah.
Been working on it since night one. Have seat size up's done, determined it's safe. We got our BSI, we got a number of patients, we got all that stuff. Additional resources. Then we check to see if they're alive. Airway, breathing, circulation, primary assessment. We don't do anything else until we have secured the airway, the breathing, and make sure they have a pulse and bleeding has stopped. Nothing else matters until those are taken care of. That is the number one thing people fail on in their team events, which are gonna start tonight. Number one thing they fail on is the primary assessment. Primary assessment done, we go into history taking. And then if it's a trauma, we do a trauma assessment. If it's a medical, we do a medical assessment. We look at the positive findings, form our primary impression, and treat our patients. Any questions? All right. Screen size up. We're gonna take it step by step. Body substance isolation. At minimum, gloves must be worn. You got respiratory call, you should probably wear a mask. So, the cloth mask, paper mask. You wear that to protect you from air particles or spit particles, that way you wear it.
Let's get to your point. Protect the patient.
Kinda, what else? Actually, more than one thing. It actually protect you. What does it protect you from then? It's not to stop air and water droplets. The number one way that you get viruses is by indirect contact, of touching the virus or something with the virus on the surface, touching your face. If you have a barrier between your fingers and your face, that stops you from transmitting the virus into you. That's why masks are important in those situations. You got someone that's got COVID or the flu or tuberculosis, actually tuberculosis is airborne. So. But something like that, gastroenteritis, the other big food disease. I can't think of it. Oh well, anyway, C. diff. Those things, everything those people touch is contaminated. Door handles, edge of the bed, countertops, the window, anything they touch is contaminated. Then you touch it, then touch your face. That's how you get sick. You have to constantly wash your hands, wear gloves. In the situation of someone that's sick, you might want to consider wearing a mask. Or make sure you absolutely are never touching your face, even scratching. Is there anybody that didn't get their picture taken? Anybody that didn't get their shirt size? All right, 24 of them?
Yes, let's see here, I'm missing, is Suzanne here?
Suzanne dropped.
Okay, thank you. Can I give one packet to somebody?
Packet.
Yeah, it's from fire packing.
Sure.
Okay, thank you. And then we're done.
All right. So other things you can wear, eye protection, very good if someone is hacking at things, you get spit in your eyes, good way to get sick. A gown in severe contamination for people that are highly contagious. Some of the best BSI out there is firefighter turnout gear. Blood, puke, poop really does not get through turnout gear. Any questions? Turnout gear is hot, just so you're aware. It's also heavy.
Yeah, you get a virus, you turn into venom.
You turn into venom. You can also turn into Peter Parker. It could be a positive thing instead of a negative.
Venom is pretty cool, though, you gotta eat people. Isn't venom a parasite? Alien, dude.
Really?
Fictional.
Any questions on BSI? All right, scene safety. What's wrong with this scene? Guy hiding in the bushes in a Godzilla costume that can't get the head off. Stuck on it. Smoke a cigarette. Sets his hair on fire. All right, so what are the things you gotta be watching for if you're sizing up a scene? Oncoming traffic, traffic collisions and getting hit by cars on scene is the #1 line of duty death for all emergency services, fire, police, ambulance. Understanding unstable surfaces. We're about to go into the unstable surface time of year. Frozen stuff, snow, wet and slippery. Same thing when you're off-road, rocks, loose dirt, things like that. Leaking gasoline, you may want to make sure if you're in a car wreck, you are uphill and upwind at all times. Down power lines, unbelievable how many times that kills people. Potential for violence, I got some videos on that. Fire and smoke, hazardous materials. Other people crash, you're gonna see if one car is already wrecked, there's a great chance another car is gonna do the same thing. And of course, crime scenes, people always return to the scene of the crime. Seriously. You'd be amazed how many times crime scenes come back and then become unsafe. I know the paramedic that was working was on the scene of a gunshot victim, shooter was at large, 8 cops on scene. Bystander walks up to him and says, "Is he gonna make it?" And he says, "Yeah, I think so." He goes, "Okay." Reaches into his coat, pulls a handgun out, shoots the guy 4 more times on the gurney. In front of 8 cops and ambulance, fire, everybody.
That was not a
He didn't live.
Yeah, oh.
Any questions? All right, you never know what's gonna happen, so be prepared. I guarantee these people weren't thinking of this happening. Candle. Guarantee you, nobody expected that to happen. They set that Roman candle to go away from people, did everything right. Here's another great example of you don't control anything that anyone else thinks, says, or does. No matter how much of an authority or how good you think you are, you have no control over anyone else. You only have control over you. And people will do and say the most unexpected things that you could possibly imagine.
Reason it's kind of chill is because the Callaway are hanging out there.
The guy said, "Oh, I just came from work." What kind of work do you have your hands? What do you do? Because there are people that are just paranoid. They think the cops are out to get them. Now, I think that this woman's been stopped twice for the same thing. Kid standing up in the car. Okay? Take a look.
Policeman insurance. Why you get on me? I'm not getting on you. What's happening is, this is the second time now for the same thing. The seatbelt. She didn't get back. She was standing up. She is not. Seatbelt, play it right here. Why? Take your driver's license. You hate me for what? Oh, I don't hate you. I like you. I'm looking out for your welfare. I hate to see your little one get up. She's gorgeous. I pray every day that you will be fed. If you miss this authority, there's nothing wrong happening to you. What happened to you? If you have the children cry like you said, you would understand.
Yeah, I have 2 children. I keep them child seats all the time.
Calm down for a second. Don't fight with me again, otherwise you're gonna regret it. Calm down for a second.
The police officers.
This next one, I want you guys to be really aware of, because this happens all the time. I know of at least 5 times, 6 times, I can think of right off the top of my head, this happening right here. This is a scene safety thing you have to watch out for.
Whose utmost concern is for the safety of the driver, and you'll see why. Take a look.
Yes, come on over here, man. If you're up here and anybody hits the back of my patrol car, there's a good chance you're gonna get caught somewhere between that car and your car. And if you're not caught in between, you may still get struck by one of the vehicles. I don't want that to happen to you.
See, I told you. It's a nightmare. Be right back with Tom Arnold right now.
Record of safe area, law enforcement is in charge of the scene. You have an unsafe scene, make sure law enforcement, well, you don't control them, but make sure it gets taken care of.
Got me blonde hair and gray outfit over here. Patrol 665, I'll be out with one. Went to the rear of the Westwood Hall. Yeah, he's got a problem. He looks a little amped up. What's going on? Step to the car and take your hands out of your pockets. Take your hands out of your pockets and step up to my car. That's the second time I've asked you, making me nervous. Take your hands out of your pockets and step up to my car. Take your hands out of your pockets and.
He's gonna wanna leave that, I guess.
Now put your hands behind your back, or you're gonna get the taser. How much have you been drinking? Huh? How old are you, man?
22.
Where's your ID?
Hey, what the you think it is?
You can chill out, or you can go to jail.
What's that?
I feel like Darth Vader.
Oh, it was great. One of the best takedowns I've ever
I
seen.
love how somebody knew he was gonna do that, so you can do a little casual
Yeah.
sidestep.
That's one of the best ever. This guy is too close to this. What do you call that?
That's what I'm saying.
This is ridiculous. It's snow and fog, big.
The other thing that people are doing is they're getting out of their vehicles, which is the worst mistake you can make. Stay in the vehicle, let the vehicle take the energy and absorb the energy. You get out, you're a sitting duck, and you cannot run on an icy surface.
Together, and it makes the visibility down to 0. And oh, watch out, watch out! Oh my God!
That guy is by inches.
Yep.
My car is gone. I need to get all my tail out of my car, but it's too dangerous. And it's on fire. I need to get off the road. This is great. My car. No. Look at that fire. Oh my God. This is crazy, man. What am I going to do about the charger? My charger. Oh my God. I don't know what that truck is on. Oh my God, those fires is crazy over there. I'm not going over there. I'm gonna check out the action over here. Woo! You don't remember the car she was driving. And I think it's good. I'm gonna try to see if I can start saving people if they're hurt. So, oh my God, that fire. Oh man, I'm gonna go see if I can help someone. I gotta let you guys go. I'm sorry.
All right, mechanism injury. So mechanism injury is important. It helps the surgeons determine where to start cutting. So now the amount of force, where it was applied to the body, for how long, and what parts were involved. It's a good mechanism injury video. Why would anyone do that? Because people very.
That's why.
Well, yeah, if it wasn't real like that, we wouldn't have a job. Nature of all this is for non-trauma patients. When someone's sick, it's a medical. You're looking for clues of what their chief complaint is and what's causing the illness. So here's a great example. What's causing the illness?
Looks like it's gonna be a great race.
Why?
Yeah, I guess.
You know around here, huh?
Yeah.
Well, good luck. It goes like this.
For the great taste that will fill you up and never let you down.
Nice. Thanks.
Bud Light.
I thought him drinking the Bud Light was me. So,
Easy in the peanut gallery. Importance of mechanism injury helps you understand where the person's injured and where to treat first. So watch this mechanism injury and tell me if you know what is wrong or where they should start looking. And listen.
Oh my God.
Oh, shit, you gotta help me right now.
Hold your hand. Shit.
Your leg's caught.
That's a tip fracture.
Yeah.
And a good one.
Oh, yeah. Oh my God. Help! Oh, shit, you gotta help me right now.
Hold your.
All right, so you gotta determine the number of patients, so you know what additional resources you might need. You never know how many patients you're gonna have. Oh. So, when I was a youngster, back before the industrial era, I honestly believed if I ever was in a car accident, I'd want to be ejected from the car, because I had a fear of burning to death inside the car. I figured it'd be better to eject, fly away, than land and roll. Yeah. Because I had no concept of kinematic energy and force, and that when you get ejected from a vehicle, you're traveling faster than the speed of the vehicle, and you're going to hit a solid object at that speed. And then the vehicle's usually going the same trajectory as you, and usually lands on top of you. It wasn't until I got an EMS that I understood all these things. So this is a great example of 3 people, 2 that are ejected, and 1 that's inside the car that is on fire and burning. 2 of the 3 people in this video died. 1 survives.
Don't have to go very far.
This is a great video for anyone that thinks getting ejected from a vehicle is better than being trapped in a burning vehicle.
A dark black cloud in the distance says it all. The chase is over. To find the Toyota now smashed, only moments after smacking into a light pole. It's still pit.
That's a body in the driveway. The other body's on the front porch. Ejected when they hit the pole, they went out the windows, through the windows. 1 in the driveway, 1 in the porch. Driver's still pinned inside the vehicle.
Underneath, the car is on fire and the electrical wires are still hot. Adam Myers is one of the first to arrive at the scene.
When we arrived, we saw bodies that had been ejected from the vehicle.
Cops know nothing about scene safety. When you watch this video.
You can see that they were injured, and so obviously our first.
You see that? That is not a secure scene. You see that? That is a burning vehicle. That is not a secure scene.
Concern was for their safety and to get them away from the light pole and this fire to the vehicle that was on fire at the time.
Concern.
I'm expecting the vehicle to explode. Some of the officers were warning each other, amongst
For those of you that are going to the fire academy, if you spray the extinguisher from 30 feet away, it's going to be very non-effective.
Yeah, I noticed.
It's not like shooting a gun from 30 feet away. It's very effective. Fire extinguishers don't work from that distance. In case you're wondering.
Try to douse the flames. But it's too late. The officers run for cover. The pole's transformer explodes. Sparks flying in all directions. Spread. Officers now race in to rescue the suspects from the fiery aftermath. The good news is the driver survives the catastrophe. Sadly, the other passengers couldn't hold on and perished from the crash. As for the driver, he gets charged with attempting to elude the police and 2 counts of vehicular homicide. They don't have to go very far.
Do not go into a burning vehicle to pull a person out like that. That is not an example of what to do. By the book, do not do that. That was seriously risky for those guys to do that. All right. Additional resources, more ambulances, more fire rescue, advanced life support, extrication, tactical, fire, rescue, specialized rescue, whatever resources you think you might need. And always be thinking in the back of your head about immobilizing the spine or at least keeping them to hold still. Any questions about scene size of? It's so dark. Because I turned off the lights. Come on. That's the easiest question you guys know all week. Okay. Develop a general impression. This is your primary assessment. We're done with scene size up. Any questions on scene size up? All right. Develop a general impression. ABPU, alert, their eyes open. They're not open. Hey, Annie, are you okay? Do they open to voice? Heard them. Eyes don't open to pain. We've determined they're unresponsive. ABPU. Assess their circulation. If they're unresponsive, we should go straight to the carotid pulse. See if they are alive. If they are responsive, we should do the paramedic handshake. Hi, I'm Brian. I'm paramedic, Mass Shasta Ambulance. Check the radial pulse while I'm shaking their hand. Is it okay if I help you today? Now go sanitize your hand. God knows what I've touched on calls today.
Did you not wash your hands after?
Huh?
Did you
I
not
didn't
wash
touch
your?
your face,
Oh,
but just kidding, don't do this. Are they breathing? And if they are breathing, are they breathing adequately? It's not just breathing. Are they breathing adequately enough to sustain life? Order oxygen. And are they a priority patient or not based off your ABCs? Any questions on the primary assessment? Moving on. Develop a general impression. So you really can't do that. That's a little bit out of order. You develop a general impression off the primary assessment. If they're not breathing, they're bleeding out, they don't have a pulse. Airways obstructed. If your primary assessment's good, you're gonna develop a general impression after you're done with your assessment. Make sure you get consent. One of the four. What is the patient's chief complaint? What do they feel is the biggest problem right now? May not be the biggest problem, but what do they think it is? That's what the chief complaint is. Any questions? Any questions on ABPU? Look how dramatic that is. What a pose. I gotta get them pictures. So if they are alert, check to see if they are alert, person, place, time of event. If they are, that's alert oriented time. One of the biggest documentation errors I see as a CQI director, you'll alert to voice or alert to pain. If you have to hurt them or speak to them, they are not alert. It's eyes open to voice, eyes open to pain, not alert to. If they're alert, their eyes are open spontaneously. Do they know who they are? Do they know where they are? Do they know what day it is? Do they know what the hell happened? Any questions? If they are not, then they lose a point on that. Alert already times 3, alert already times 2. Yes. Yeah, when they're alert, they don't know anything. It's actually not that uncommon. If I don't get at least 400 milligrams of caffeine, I'm alert already times 0. Any questions? Don't call 911. Bring an energy drink. I'm just kidding. I miss Pepsi Max a lot. I really, really, really like Pepsi Max. Huh? I love Jones. Huh?
I think those are pre-workouts.
Well, they are pre-workouts, but they have 200 milligrams of caffeine and a bunch of other stuff that works really, really well for staying awake.
the Reigns have like 300.
They do, and so did some of the banks. I think Bang's gone now. They got sued.
Really?
Huh?
Oh, it's awesome.
Yeah. Yeah, Ben got sued by Monster for proprietary, they did some proprietary no-nos. Yeah, that's why. All right. And then, yeah, Pepsi went and totally changed Pepsi Max, took all the extra caffeine and the guarana out of it, completely ruined it. It's just, I sent them so many angry tweets and they didn't care.
Yeah.
All right, assessing the pulse. Again, they're unresponsive, carotid. If they're awake, see if they got a radial. The other important thing is if they have a radial, you know their systolic blood pressure is at least 80. That's an EMS trick. It takes at least 80 millimeters of mercury to get a pulse out to the wrist. Generally, the general rule of thumb is they don't have a radial pulse, their blood pressure is low. Any questions? Yes, it takes 80 millimeters of mercury to get a systolic pressure of 80 out to the wrist. So the general rule of thumb is if you don't have a radial pulse, systolic pressure is probably not up to 80. Now that's not an absolute. There are some people that can have radial pulse and a blood pressure of 60, depending on their health and their condition. There's some people that have a blood pressure above 80 and not have radial pulse, but it's a general rule of thumb. Any questions? And do they have any uncontrolled bleeding? If you do not stop the bleeding, they will likely bleed to death. And it's your job as an EMT to stop the bleeding, so stop it. Any questions? Is that too fast? If I take too much caffeine, I start to sound like an auctioneer. Just stop me. So, signs of inadequate breathing or airway compromise. Speaking in whole sentences is huge. If someone can speak a whole sentence without taking a breath, that's generally adequate breathing. If they have to take a breath after every 2 to 3 words, they're hedging on the edge of the inadequate breathing. That 1 word sentences, so they have to take a breath in between each word, they're not breathing adequately. Use of accessory muscles, you'll see it in their neck and their clavicles. They got to use those muscles. They're in severe respiratory distress. And their nares are flaring, it's going out and in like an angry bull. That's a bad sign. And of course, elevated noisy breathing. Any questions? So if they're unconscious and not breathing, then you gotta check to make sure they don't have an airway obstruction. You can visualize it, look for obvious trauma. Sometimes teeth, pieces of the tongue, the interior cheek get lodged in the airway by gravity. Noisy breath sounds, if you're going over that, bubbling, gurgling, crowing. Or if they're just breathing too shallow or too slow, that's inadequate breathing. Any questions? Things you want to notice, are they choking? Are they breathing too fast or too slow? How deep are they breathing? Are they turning blue? They get turn with a little blue around their nose tip, their fingertips, their lips. What do their lungs sound like? You guys, you're checking lung sounds every day. You're going to listen to a lot of healthy lung sounds. And I've been criticized like, oh, I've listened to 1,000 lung sounds in Witherell's class. That's a good thing, because then when something's not right, you're going to know it immediately. You're going to have confidence knowing it's not right, because you've listened to 1,000 healthy ones. Make sense? It's actually a method to the madness. And how much air are they moving? Any questions? All right. So here's a pretty good video on how to do lung sounds. They're not too good this way to feel because it take you forever and you never get away from the scene. And honestly, her boyfriend is did this. I think it's a serial killer. You look how dark his eyes are. But it's a pretty good demonstration of how and where to take.
Hey everyone, it's Sarah, registerednursern.com, and in this video, I'm going to demonstrate for you on a patient how to auscultate the lungs anteriorly and posteriorly. In the previous video, I went over an in-depth lecture about how to do this along with normal breath sounds and abnormal breath sounds. So be sure to check out that video. after you watch this. So let's get started. First, I want to start out showing you the auscultation sites. I wanted to use these stickers so you can see about where I'm going to go with the stethoscope. And let me go over these real fast for you because these are the little landmarks of where you're going. We have our right lung over here and our left lung over here. And what we're doing is we're assessing the lungs. The right lung has 3 lobes, the right upper, the right middle, and the right lower.
Pretty cool, because most of your patients will have color-coded dots on where to put the stethoscope on.
Yeah.
Yeah.
Really?
Yeah, absolutely.
Oh, cool.
No.
The left lung only has 2 lobes, the left upper and the left lower. So whenever you're listening, you want to start out at your apex up at the top of the lungs, right above the clavicle, just slightly above it, right here where you see these pink stickers. Then you're going to go down to the second intercostal space, a little bit over from where your breastbone is, the sternum. And this is where you're going to start assessing the upper lobes of the lung. Then you're just going to inch down a little bit and you will, this is about the 3rd intercostal space, and you're going to listen here. Then go down to the 4th intercostal space. And this is one of the landmarks for the right middle lobe, your 4th intercostal space. So right here, we'll listen over here, our right middle lobe, and then we'll listen to our left upper lobe. Then we'll inch down a little bit and we'll listen a little bit more to that right middle lobe. And then we're going to be listening to our left lobe. And then we're going to go mid-axillary over here to the side where the armpit is, mid-axillary, 6th intercostal space, and we're going to be assessing our lower lobe. So it's right here on him, and then it's again right here. And you'll listen there.
You see how thrilled he is when you're doing this video?
Yeah, he's like staring into my soul.
Yeah. It's very.
Yeah, it is.
No way he doesn't say that.
Personally, I think we should have used this guy for the Jeffrey Dahmer documentary.
And then you'll just inch down a little bit and listen at the bottom just to assess those lower lobes a little bit. Now let's listen to the lungs with a stethoscope. Okay, before you begin, what you want to do is you want to perform hand hygiene, introduce yourself to the patient, and tell them what you're going to be doing. And whenever I listen to lung sounds, I like to listen directly on the skin with my stethoscope, not over the gown or over their clothing, because you can pick up other sounds that may sound adventitious when it's really not, and you just get the best acoustic sound whenever you listen directly on the patient. So you want to get your stethoscope and you want to listen with the diaphragm of your stethoscope because that's what picks up the best sounds. And what we're listening for is we're listening for that full cycle of inspiration and expiration. And we're paying attention to what type of breath sound is it? Is it bronchial, vesicular, broncho-vesicular? If you're not familiar with those sounds, check out my other videos because I have audio clips where you can listen to those. And we're also listening for any extra sounds on top of those sounds, like crackles, wheezes, stridor, anything like that that we may be picking up. And another key is this skill takes getting used to. You have to practice it over and over, especially when you're listening over these areas because you're going to hear the heartbeat at the same time. So you got to train your ears to listen for those correct sounds, like the heart versus lung. So practice this on yourself and on others so you can get comfortable with it. So what we're going to do is we're going to start at the top and we're going to work our way down. And we're going to start on one side and then compare that side. Because we want to see if we're hearing the same thing on this side as we are that side. So let's get started. Okay, what I'm going to have you do is take one breath in through your mouth and out through your mouth. And if you start to get dizzy or anything, let me know. We can slow down, okay? We're starting up at the apex, right above the clavicle. Now we're going to inch down to the second intercostal space, and this is where we're going to start listening to our upper lobes of our lungs. So it's about right there. Then we're just going to inch down a little bit to about the third intercostal space. And listen there. And we're going to go over and compare it. Now we're going to go down to the fourth intercostal space. And we're still going to be in the upper lobe of the left lung, but now we're going to be in the middle lobe of the right lung. So let's just go down just a little bit. Then we're going to go over here and compare. And then we'll just go a little bit down, maybe the fifth intercostal space, just still assessing that middle lobe. And go over here and compare. Now we're going to go mid-axillary, and we're going to be down in our lower lobes now. And this will be at the sixth intercostal space. Okay, we're going to compare sides. So if you just want to turn over here, we're going to go mid-axillary, compare side. Then we're just going to go down just a little bit to stay in that lower lobe. And then we're going to compare sides. Now let's look at the posterior view of the back. Here, over on this side, we have the left lung, and over here we have the right lung. It's flipped compared to the anterior view. And what we'll do is we'll start listening up at the apex of the lungs again, and that's right above, slightly above that shoulder blade in this area where the green stickers are. Then we're going to go and we're going to listen between C7 to T3. And C7 is where your prominence starts, so right here, and we'll go a little bit below it, because C7 to T3 is going to assess the upper lobes of the posterior side of the lungs. So we'll go here and here, then we'll go down just a little bit. This is about where T3 is. And then we'll jump down to around T4. And from T3 to T10, we'll be assessing the lower lobes. In your posterior view, you have more ability to auscultate the lower lobes than compared to the anterior view where you're going to really be assessing the upper lobes. So then we'll just go down, listen here, listen there, we'll go there, and then we'll just go a little bit mid-axillary, almost mid-axillary, and listen over on these sides, and then down at the bottom and over here. Now let's do it with a stethoscope. Now we're going to listen posteriorly. Okay, let me tell you a trick with this. Whenever you're listening back here, as you learned if you watch the other lectures, you have the scapula back here and you have the vertebrae. And what you're trying to do is to get in between that scapula and vertebrae to listen to those lungs. And you don't want to go over the shoulder blades of scapula while you're listening to lungs, because it's really going to muffle out your sound and you're not going to hear a lot. So what you need to do is have the patient sort of just move their arms like this to separate those shoulder blades from one another, so you have some space to work with. So what we're going to do again, we're going to start from top and work our way to the bottom, and we're going to compare sides. So we're going to go slightly above the scapula and listen to the apex. Then we're going to go down in the area where C7 is, which is where your prominence is. Then we'll work our way down to where T3. And remember, this is assessing the upper lobes. And then we'll go down from T3 to about T10 and assess those lower lobes. So here we go. And again, just take good deep breaths for me in and out. Okay, and we're done with posterior. Okay, so that is how you assess the lungs with a stethoscope. Now be sure to check out the other videos in this lung series. All
right, now this is what you're listening for.
It's Wes. Susan Wes, that is. In this video, I want to talk to you about the breath sounds that are often referred to as rales, bronchi, and crackles. Which is which? What do you use for more practical purposes when you're actually working and charting and giving a report or making a doctor call, this more accurately describes what you should report. Rails and Montai are outdated terms, and nobody really knows what they mean. The term you should use is crackles. But there's three different things you should include with the term crackles. First, the type of crackles. Are they fine crackles? Are they medium crackles? Or are they coarse crackles? And when do you hear them? Do you hear them during inspiration? Do you hear them during expiration? What part of inspiration and expiration do you hear them in? And where are they in the lungs? Right below the lobe, or they in the whole left side, bilaterally? That will give you a good description of the breath sounds. Crackles happen when there is air passing through and around fluid and mucus in the lungs, main stem, bronchus, or upper airway. An exception to that is atelectatic crackles, and of course caused by atelectasis. Atelectatic crackles are fine crackles in the end inspiratory phase, and they're usually in the lower lobes. My diagram here shows inspiration and expiration. Fine crackles sound like Velcro ripping apart. They can be atelectatic crackles, or they might be the beginning of fluid overload or pulmonary edema. Medium crackles usually scattered about, and the fluid's getting more built up, or there's swim present. Coarse crackles usually when there's a lot of phlegm and fluid present. A few notes about crackles. If you hear crackles and you listen to somebody's chest, it's in their upper airway, their nose, back of the throat, it will echo all through their lungs. So ask them to clear their throat. And also, if the phlegm's in their chest, ask them to cough. See if it resolves itself. You don't want to disregard it because they were able to cough it out. But you want to be able to charge that they were able to clear it out. But saying what the phlegm looked like. Also, if your patient has an endotracheal tube or a trach tube, crackles are not normal breath sounds. They should have clear breath sounds just like everybody else. It just means that they need to be cleared out. They need to cough it up, and if needed, suction it through the tube. So just to summarize, the crackles are either fine, medium, or coarse. For when they happen in inhalation or exhalation, and where they're at in the lung. Okay, thank you so much. Bye-bye.
Thanks, Super Wes. All right, so when we give high flow to anyone that's major trauma, decreased level of consciousness, anyone that's in severe respiratory distress or signs of shock. But we never order it if they have inadequate respiration. It's always going to be BVM, and you never order O2 before you assess adequacy of breathing. Any questions? All right, so you know what? Put the patient in a position of comfort. If they're in respiratory distress, it's probably our chest pain. It's probably going to be a sitting position. Any questions? All right, perfusion. Your skin signs are going to be your best indication of how well someone is perfusing. We go over shock here very soon. We're going to go over that in detail. But the skin should be of normal color, warm temperature, and dry skin. Capillary refill time. Anybody can do capillary refill. Pitch underneath your nail bed. It'll turn white when you let off your pitch. How long does it take to turn back to the color it was before? It should be less than 2 seconds. If it's more than 2 seconds, we have a problem. In kids, capillary refill time is the only true test for shock, because kids compensate for shock so well. We're going to go over shock compensation, I believe, in our next presentation, which will probably be Thursday night. Any questions? We might get to part of it today. So who's a priority patient? Anyone with difficulty breathing? Anyone that looks like they're going to die? Anyone that's unresponsive? Severe chest pain or any signs of shock? Any questions? All right. So, if their primary assessment, if you've got a critical patient from your primary assessment, you should probably start moving towards the hospital if you are an ambulance. If you're not an ambulance, you're probably getting them in packaged in a position so when the ambulance goes, you can throw them into the ambulance as it's driving by. That's a, not really, but you know what I mean. Any questions? to narrow it down to the narrowest scene time possible. Any questions? Now, that takes us through it. What's next? Scene size up, primary assessment, then history taking. So we take history. Want to know if they know all the presidents in order, states and capitals? No, just kidding. All right, sample, signs and symptoms. Which then we can define out the symptoms with an OPQRST. We want to know if they're allergic to medications. That's critically important so that the paramedics or the ER does not give them a medication that will kill them. We also need to know what medications they're taking, so the medications the paramedics or the hospital might give them does not have an adverse reaction with the medications they're already on. So both those are critical questions. Past medical history is extremely important to help you in your assessment, so you know what potentially could be wrong. Last meal is also critically important because they're going to go under anesthesia for an emergency surgery. What type of anesthesia they use, depending on how much food is likely in their stomach. And the next big question is, how did this happen? What were the events that led up to this? That is how you take a history. Any questions? All right, your OPQRST is how? What? OPQRST? All right, OPQRST is how you define out your symptoms. Onset, when did this start? P, provoked. What caused this? Q is for quality. What does it feel like? You describe what it feels like. R, radiation. Does it shoot off anywhere? S is for severity. How severe is it? And T is for time. But wait a minute, we already have onset. So time means, is it intermittent? How long does it last? Or is it constant? The question of the OPQRST to define your symptoms. All right, we're done with the history. That brings us to the physical exam. Physical exam is a critical patient, should be done in 60 to 90 seconds. So we're going to start this time. You guys have a 10-minute time limit. Go in, assess the patient, package the patient with need, and transport them with at least 2 sets of vitals. It's going to feel like it's impossible. When you go on your ride-alongs, if you're riding along on B, you're going to see from patient contact to inside the ER door sometimes in 7 to 8 minutes. Seriously, it's very doable, especially if you have an excellent interactive team. All right, let's go over how to do that. DCAP BTLS, I know Tom went over that last night with you. If you say that during the skills, you can say that. The proctors are probably going to call you out of it. They're going to ask you what it means. And if you can't give them all 8 of them, you're going to fail. Questions? That's what you're looking for on the head to toe. DCAP BTLS. All right. You're going to assess the head. DCAP BTLS. You're going to check the pupils, make sure they're equal, round, reactive to light. That's abbreviated PEARL. Pupils equal, round, reactive to light. PERRL. It's not spelled right, but that's what it's called. You're going to look at the neck. You're going to check C1 through 7 for tenderness, deformities. You're going to look for jugular vein distension. And if it's potential spinal mobilization, you're going to hold them still, not let go. Maybe put a collar on them. You're going to assess the chest for DCAP BTLS. You also have the exposure patient if they're a trauma patient. Can't do DCAP BTLS if the patient's not exposed. You're going to listen to lunge sounds. You check for rigidity. Same with the abdomen. You're going to make sure it's soft, fat, tender. You're going to check for DCAP BTLS. If you have no pelvic pain, you're going to skip the pelvis. If you don't have no pelvic pain, then you're going to press on the pelvis in and down to make sure if they have instability of the pelvis. If they have pain existing in the pelvis already, you're gonna assume that it's unstable and you're not gonna press on it and move those plates and cut an artery. You're gonna look down all four extremities after you expose them for decap ETLS. And you're gonna make sure they have good circulation, sensation, and movement at all the distal points of their fingers and toes, if they're still attached. Vital signs should be being done by somebody while you're doing the assessment. Then after you package your patient and start a transfer, you should have a second set. The critical patient, they should be taken every 5 minutes. They're a non-critical patient every 10. Remember, the vital signs are numbers that are used as guidance to how the patient's cardiovascular system is working, and they are just numbers. Never base your primary impression of your patient off just the numbers of vital signs. All of your positive findings together should form your primary impression. Any questions? No questions, huh? Skin signs, blood pressure, pulse, respirations, SpO2, and the Glasgow Coma Scale. You need to have the Glasgow Coma Scale memorized. There will be test questions on it. The cool thing about a Glasgow Coma Scale is the best score you can get is a 15. And even people that have the worst score possible, dead people, even have 1 of 3 consolation points. So start with the eyes. It's your ABPU that you already know. You get 4 if the eyes are alert, 3 if they open to voice, 2 if they open to pain. Nothing at all, you still give them a point. Any questions? What's that?
Just, can you give this?
Yeah. Then they're verbal. Are they alert, oriented, person, place, time, and event? If they are, they get 5 points on top of whatever points you gave them for their eyes. If they're missing one of the alert and oriented, they're not oriented, person, place, time, and event, or are missing any one of those, they get 4 points. If you ask a person, place, time, and event, they say, the cat's peeing in this area. That's inappropriate. That's 3 points. If you ask a person, place, time, and event, they say, that's incomprehensible. That's 2 points. If they have no verbal at all, that's 1 point. We add the eyes and the motor together. Then we go to our eyes and verbal together. Then we go to motor. If they can obey simple commands, they get 6 points. If they do not obey simple commands, but they're still moving their extremities purposefully, they get 5 points. If they're not moving at all, but they withdraw when you hurt them, that's 4 points. They're doing a flexation like this, that's 3 points. It's also very bad neurological damage. And if they're doing this, that's even worse. That's 2 points. That's called extension. And if they're not moving at all, they get 1 point. You add the 3 categories together, that's the Glasgow Coma Scale. Any questions? The extension, I got some videos of fencing response. You guys ever seen that before? Sports, someone gets their bell rung at the bell. Happens all the time.
Getting knocked out, yes.
Yeah, Ronaldo Nehemiah, probably nobody knows who that is anymore. He was an all-time track star. Jerry Rice convinced to be a wide receiver, but only weighed like 130 pounds. He went running into traffic and a quarterback and a free safety both hit him, knocked him out cold. I got some video. There's actually now we got video at all sporting events. We got tons of videos. Okay, to move forward with the Glasgow.
Yeah.
All right. I think this is that video. Yep.
Fit and playing well. Suddenly looks impressive. Oh! Yes. That move, wonderful courage from both players. It was a terrible pass and put him in there.
Like rugby, they keep playing.
opportunity, the hand pass comes across from Pickens. But the concern is with Lewis. Jordan Lewis. The stretch it out.
Best question of the fencing response, it's not about bad neighbors. So it's still running. Discontinued case. That's still fighting.
Orr is known to have a tremendous right hand, and all these guys are, and he's out cold. Hit him right on the side of the jaw.
Simmons, Ryan Thornton is still down.
Out. Two.
You can see ahead of Rayleigh going back into Bryson. He's got a full speed hit Lidstrom. He didn't even touch the, he tried to get his foot down and he stumbled and it's, you can see Ryan Johnson's right foot, as he goes to plant it, he can't.
Any questions? All right. Then we reassess. Go back and do a detailed exam. Any questions? No questions? So what are we looking for in the reassessments? The treatment improving? Is the patient getting better or are they getting worse or are they stable? Any questions? You guys watched that last night? Want to watch it again? It's a good video.
Yeah.
Go!
DSI seems safe. What am I dispatched to?
You are dispatched to an assault victim sitting on the floor.
Do I need additional resources right now?
There's 2 minutes.
And cease my considerations, I will consider cease my. How long can I place the 17-year-old female without hair distress?
You have a 25-year-old male sitting on the floor.
Okay. If that hair, here, for me, right?
They look changed.
Okay. How can I find my patient? I have a feeling I have to
Hey.
You know where you're at? You know what day it is?
Patient alert.
Patient, you know, person plays time in that. I feel strawberry rolls.
You have a
Skin signs are pink one.
sometimes I think on the
Okay. I everybody needs query that she's talking to me. And she appears to be very active. At this time, I will order an honor reader and 15 years. What happened? You have anything one, no, right? Going down the back of the head, checking one of my gloves.
Yep, you, numerous lacerations and scar.
Behind the ears and the two. My pupils appear
Which is
early
on there, bro.
and no broken teeth in the mouth. My trachea is in my own letter JD
That's fine.
and rotating back to the neck.
C-spine is probably.
Okay. Let's get it. Hold on. Pain in the chest, pain.
Ow. Standard palpation on both sides.
Okay. Double deep breaths on me, right? Thumbs out your clear. I can, it says my happening right now. Do you have any pelvic pain? Okay, the pelvis. And going down the legs.
Upper extremity clear, or.
I'm supposed my patient now that I've seen any, deputy. Get the backboard behind him, clear down on the backboard, so we have heavy dependence. You have any allergies that we need to know about? Or you have any medication? Do you have any other past medical history? Going down the back real quick. Staying back. Okay, what was the last time you did? Right down real slowly, Debbie.
All right, now, 1, 2, 3.
Any of that hurt? Helping the abdomen real quick. Any pain? Keep my finger, go hard. Good. My finger like that. Push down. Pull up. Taking shoes off. Okay, and if you're gonna take that pretty still. Push stone again. Stone again. Okay, you can see it's under attack on four surface. Go ahead and drag it up real quick. Okay, down.
3, 1, 2, 3.
Stone here. We're gonna see if that allows us to do one. If you want to get that one out there. Instead of full funding is for investigations. And what happened before you got to that? My patient appears to have CCS of 15.
Full 60.
Pulse comes back at 132.
One 24 or 78.
120 over 54.
16 respirations.
Respirations are 18.
I'm gonna realize the track. Then we'll get her loaded up and get going. One, two, three. Go there. Any pain or anything else for you? The other issue? Low rest. Come back in, you guys think that a while, we're around the same one. Do you want to get to again? Anything you stand up here? Okay. One. Yes. Also some curl. No broken teeth, my airways back. Trachea appears in the limestone. Another JP. Nope. Chest is stable. Okay. Abdomen. Soft front tender. Also still stable. Other extremity to clear. Push down like you push down that test. Yeah, people. Push over.
Okay, get ready to report.
First, you guys next time, one paramedic. Three, with a 25-year-old female, who was an assault victim. Patient states when he walked out, he was beaten up. Patient is the person has 10 and 10. With wounds to the head, with blood, bleeding is controlled. Neck is negative, trachea is in line with another GED. Chest is tender compensation with pain, one sound very abdomen stop on tender, pelvis is stable. Lower extremities are negative, upper extremities move well, strong states once around. I have a current set of vitals of 132 over pulse of 132, blood pressure of 100 over 56, respiration to 18. If you have any ETA about 5 minutes, we can have a question.
All right, go to break, be back, ready to do skills at 5 minutes after 8.
Well, this lights off, I'm not ready.
So. I don't know what happened.